Okay, hello, Dr. Hassan. Can you open your camera because we are here to join our talk today. I don't know what happened from there.
Hi, how are you?
Hello. Yes, this is our talk, and we call the Coconut Cake talk. And today we will talk about the topic is a gastric cancer, and how some people can join with us, and it's not specific. Maybe have some people late. We don't know. But we are so happy when you can join with our group today to discuss about the case and sharing about the um, clinical experience or even the knowledge theater. And nice to see you here. Okay, so before we start talk, we need to know a little bit about each other. Okay, can you introduce about yourself, Dr. Hassan? Sorry, we cannot hear you well. Please speak louder or check your phone. Have problem with that.
You hear me now? Is
Yes,
better?
yes, it's better.
My name is Hassan Mustafa, and my specialty is anesthesia and intensive care, actually. I am an anesthesiologist.
Yes, he's an.
I live in USA now, in New York State. Okay, that's all.
Yes, yeah, that's it. Okay. So in here we have doctors and even these medical students, and some of them live in Vietnam, or some people they live in another country like Dr. Ho Huang, who he's living in Japan, or even Mr. Leon, who living in US now. So our group will talk about many topics every week on Saturday. Okay, so today, anyone new? I just see new people here meeting. So because Dr. Hassan is the first time he come to our talk, so I want you guys can have short introduce about yourself. Let him know about you guys first. Uh, okay, that's all.
Yeah, hi everyone. Yeah, I'm Huang. I'm a PhD student in Hiroshima University, Japan. Yeah.
Yes.
That's all.
Okay. And how about next one?
So, hello everyone, I'm Leon.
Can you open your camera because I cannot see you?
Sorry. Hello, I'm Leon. I'm a fourth year medical student in US, and I'm currently in Alabama. That's all.
That's all. Yeah, you guys today use that's all and that's all. Okay. Okay, next.
Hi everyone, I'm Long and I'm 4 years. I'm 32 years old. So that was.
Yeah. Where you studying now? I don't know.
My school near Vietnam Military Medical University.
Yeah, I remember that. Yeah, sorry. Yeah. The next one, please.
Hi.
Yeah, just go ahead, Ron.
Hi, I'm Vân and I'm the fifth year. Yeah, that's it.
Cannot hear you. Problem from your microphone too.
Can you hear me?
Okay. Let me help you. Yes, Vân, she's a medical student too, and maybe she's a fourth year, right? Fourth year medical student, right? In Taiwan University. Yes, is it correct? Okay, the last one, please check your phone again. The last one with thing, I cannot connect to him because I have problem with the communication, but let's see about it. Thing, can you hear me? Okay, So I think we can start our talk today. So Dr. Hassan, before we can start, can you talk a little bit about the gastric cancer, like what we should know about this when we learn, or even if like some the symptom or some kind from your experience when you're working or some kind of. Please speak louder because we cannot hear you.
Yeah, as I say, for the general feature, which is shared for all cancers, what like the weight loss, like anemic, that can share between all the one second, sorry.
Yes, because like why we talk about this topic, we talk about many topics related to cancer before, because we recognize in my country the number of patients who have the cancer increase every day, especially like the gastric cancer, we call like GI tract cancer in Asian country. That's the reason why we want to talk some topic related to that, not only for us to improve our speaking skill, but also about to gain more knowledge about this. Okay, so before that, maybe.
So
Yeah.
I have one idea. Before we start to the talk today, I want to ask everyone. Do you know about anything about gastric cancer? One thing or something is okay, but what do you know about gastric cancer? Just one sentence is okay.
Yeah, it's good. It's a good question, Dr. Horn.
Okay.
Can you share about this? What do you think about the gastric cancer, like from your knowledge?
Mr. Long and Big Vong.
Yeah, I know one thing that gastric ulcer can be a high risk to become to patient we have gastric cancer in the future.
And
I know some complication of gastric cancer and risk factor such as infection with Helicobacter pylori, family history, diet high salty and smoking. Yeah.
Sound like Vietnamese.
Okay, and Vong. How about?
Can you hear me?
Yeah. Okay.
Alright, about the gastric cancer.
you have problem with your microphone. Please touch. Well, I remember you when you touched it. It looked like it's louder. So please touch it.
Can you move the microphone, maybe?
Okay.
Yeah.
Can you hear me?
Okay.
Okay.
Okay. Thank you.
Sorry guys.
Actually, I don't know well about cancer because I haven't studied this subject at school. But about the gastric cancer, I think I've read that.
Sorry guys.
Yeah.
The battery is gone.
Yeah.
The stomach have 5 layers, and I remember that the cancer with starts at the innermost layer is the most benign.
Mucosa.
Okay. Sorry. What? You think like most of the gastric cancer is benign? You think like this, right?
But if the cancer starts at the innermost layer,
Again, what did you say?
She says in the most layer, mostly start in the most layer.
Okay, okay. Okay,
Well,
any
I
idea with
don't
that?
know much about gastric cancer, but I know it's associated with MEN type 1.
MEN type 1, right? Mm-hmm,
Yeah.
mm-hmm, yeah, I
Multiple
agree.
endocrine neoplasia type 1.
Mm-hmm.
And there's also forgot. Well, yeah, that's the thing I know about it.
Yeah.
But step 2.
Yes. He always mentions step 2, step 1. But you guys have anyone ask about which is called step 2 or step 1? Like this related to the test we call like USMOE, United States license examination, right? I don't remember. Like this is a test for a doctor from the international country who want to work in the US. So Mr. Leon always say step 1, step 2, some kind of that things. Okay. Yes.
I think
So
the reason why it's common in Vietnam because in Vietnam we have more H. pylori infection than anywhere else. In US we don't really have much Helicobacter pylori.
wow, yeah, I believe I agree too. Wow, yeah. So we are talking about some knowledge about gastric cancer. So Anh Hoàng, from your working experience, can you have any idea to share with us before we come to our topic today?
Yeah, actually, I working with the gastric cancer for a short time. So, in with gastric cancer in the Asian, with Asian the ratio of gastric cancer is more higher than the Western country because maybe associated with the life.
Lifestyle?
Yeah.
You mean lifestyle? Like
lifestyle?
diet?
Yeah, lifestyle. For example, with the Korean and in Japan, the number of patients with gastric cancer is very high, more than another country. So in the Japan and Korean, they have the cancer screening. Yeah, cancer screening for gastric cancer.
Yes, screening test.
Yeah, for another country, they don't have to do the screening test for gastric cancer, but with the Japan and Korean, they have.
Wow. Yeah. The first time I know because you know that I also looking for about a screening test for gastric cancer and actually from the document from the US, like they didn't mention anything about a screening test.
But in the another country, the number of the gastric cancer patient is very low, so that we don't need to do the screening test.
Yeah, that's
it's
good.
only in Korea and Japan. Yeah.
Korea
and
Korea
one more thing.
And Japan, right?
Korea, yeah. And one more thing, I agree with the lung, because the gastric cancer, it's a high risk of gastric cancer associated with the H. pylori. In Vietnam, the number of the people, everybody have the pylori. It's very common.
Very common. Near 90% people who have the H. pylori in the population. Yeah. No, not 90. Maybe it's lower, but it's too high.
I don't know, but every time I go back and I come back here,
because when we
pylori, so.
Yeah, because if we talk the 90, maybe it's include me, but I think I don't have H. pylori. I check it, but I don't have. Okay. Okay, welcome back, Dr. Hassan, because I think I have problem with your internet, and please join us again. So you are the host today, so can you start your like talk about this?
Yeah, sorry about that. Yeah, the battery. Yeah, as I said, there is a general sign. First of all, is like as I say, is weight loss or chronic iron deficiency, anemia. Mostly it's asymptomatic. It's not mean it's benign or not benign. Mostly it's asymptomatic. Only when it's like become big and close the pyloric become mechanical obstruction. So at that time, the sign and symptom actually appear. That's the reason it will be like metastatic at that time, maybe. So that's why. So always is misdiagnosed because of that. As he say, yes, it's mostly in South Asia, also because of the food, type of food what they eat there. So I think that's the reason. Is mostly like it's most high percentage in Japan, as he say, or Vietnam or whatever. It's type of food what they use there. That's why it's here is rare here in USA.
So what we eat every day?
No, I think some spice or something there. I forget the name.
Or maybe like we talk about the H. pylori, we explore the high population have the H. pylori, also increase the risk of the gastric cancer too. Alright, so very general knowledge about gastric cancer. So now we come to the some question for discussing. Based on the question, like we hope we can talk something about related to the test, or even needs about some kind of the cause can not the cause, maybe the cause or risk factor related to gastric cancer. So let's start with number one. And Dr. Hassan, can you
question?
Yeah, this question. You can ask someone to have you read that, or you can discuss, or you can do something with that question, because it's your talk. It's not me.
That depends on you. you are better
Don't
than
depend
me.
on me. Don't depend on me. I will lead you to the wrong way.
I will listen to you better.
No need. Okay.
Now, if somebody wanna start reading this question, and then we'll discuss about it, about the option, and then we'll go one after one why it's not right.
Yes.
And why it's right. Okay, so one of them is the most correct of those answer for this question. So anybody want to read the question? Like, whatever. I want me to read it.
Yeah, long. Yeah.
I can read the question.
Yeah.
A 63-year-old man comes to emergency department because of 2-day history of persistent vomiting after meals. The vomit consists of undigested food and a clear fluid. His last attempt to eat was 6 hours ago, and his last bowel movement was 3 days ago. For the past 3 weeks, the patient has had worsening nausea and early satiety. He also reports 6.8 kg, 15 pounds weight loss over the past 4 months. He has hypercholesterolemia treated with atorvastatin. The patient drinks 2 to 3 glasses of wine daily. He appears thin. His temperature is 37.2 Celsius degree, 99. I don't know how to what
you don't have to read it.
Fahrenheit. Yeah, good.
The pulse is 80 per minute, and blood pressure is 120 and 65 millimeter mercury. Examination show dry oral mucosa and conjunctival pallor. Abdominal examination show epigastric fullness with mild tenderness. A sloshing sound is heard upon aspiration of the epigastrium when rocking the patient back and forth. Which of the following is most likely to confirm the diagnosis? A. Esophageal manometry. B. Esophageal pH monitoring.
You should read esophageal.
Esophageal pH monitoring. C. Abdominal ultrasound. D. Fecal elastic measurement. E. Upper endoscopy, and F. CT angiography.
So,
the patient is old man, 63 years old. The chief complaint is today persisting vomiting after meal, and his last attempt to eat was 6 hours ago, and his last bowel movement was 3 days ago. The patient had a weight loss about 6.8 kilogram over the past 4 months. In abdominal examination, so epigastric fullness with meal tenderness. A sloshing sound is heard upon aspiration of the epigastrium when rocking the patient back and forth. So I think we must do upper endoscopy. E.
so you mean like you want to choose E, upper endoscopy? So,
Yeah.
so how about the others? How you think, Dr. Hassan? How do you think about his opinion?
First thing is the age. We will go with the age. First one, he's old, 63 years old, and lose weight. That's what we say. The general share sign and symptom for all cancer is losing weight, which is obvious. He's 6.8. He's losing weight, and the other things. There is the mechanical symptom. What we see here, the sign and symptom here in the question. So, anybody just make sure from the mechanical symptom.
I think it's undigested food and clear fluid. Sound like obstruction, maybe mechanical symptoms.
Yeah, they say nausea. He had nausea. He had vomiting.
So nausea and vomiting is mean like patient have mechanical symptoms. So how can we recognize the mechanical symptoms?
Pain.
Mm-hmm.
Pain.
Anything else?
Mm. There is sign and there is symptom, so they should differentiate between them.
So we need to differentiate between the sign and the symptoms. That's what you mean? So which is the sign and which is symptoms, you think?
So the patient what he complained, like he had pain, he had nausea. I mean,
So
sign,
it's
what we see when we examine the patient, like when suction splash, when you see here, then the question what they say here. They say there's a sloshing sound, is hearing upon auscultation. This is sign. There's obstruction. Pylorus stenosis actually That's what we have. This is what they call suction splash. When they rock the patient and they put when they do auscultation as the stethoscope on the gastric area, when they rock the patient left, right, you will hear that sloshing sound. That's the main sign of there is gastric obstruction. Pyloric stenosis. That's what.
Yes. Can you speak clear, because I believe in here like some students cannot hear you clearly because your voice is quite like low and we cannot like hear you clearly. So please speak clear.
Part, I say there is sign and symptom.
Yes.
Yes. Symptom when the patient come in and he say I have vomiting, I have metamesis. I mean that's all symptom. I mean sign when you examine the patient, what you see like he had he had when we put the I say examine the patient, what we see like sign of anemia, sign of a mechanical obstruction like pyloric stenosis. I mean, so the main one to me is the I say suction splash when we hear on auscultation the sloshing sign or sound when we rock the patient left and right, so we can hear that sloshing sign. That's one of the main of sign. Okay. Symptom, as I say, is nausea, vomiting, pain, all those, and with the general symptom like losing weight. Okay.
Yeah. Thank you. That's really good idea for that. Yeah. So we need to differentiate between sign and symptom based on Dr. Hassan can help us to like divide two parts. This can make you guys clear to look at the clinical picture better than just go like with many symptoms together. They just give a lot of things here. Okay, keep continue, Dr. Hassan. We are waiting for you.
Okay, I'm waiting the people talking about that.
No.
Yeah. So how we can diagnose that? What the diagnosis? How we with the question now? How we diagnose that? What we will go first when we see this patient? What we will do? Depending on his age, depending on his sign and symptom, what we will do? That's the question.
Yeah. In this patient, I can list some problem with this patient. As you know, you know about the sign and symptom. I can say that the patient with the symptom of the patient is vomiting, nose, weight loss, and the sign of the patient is consumptive pallor, gastric fullness, and tenderness, sloshing sound. Yeah, and based on the sign and symptom of patient, I think he had the problem with the gastric, the upper of the GI tract. For example, gastric or the somewhere around the gastric.
You mean like maybe gastritis or maybe this like tumor? Like what you mean, right? Have problem in there?
Yeah, had problem, and maybe some problem make the obstruction in the
obstruction. Yep.
Yeah, obstruction in the upper of the GI tract. It make the food cannot go through go through along the GI tract, and so that he have to feel the nose or and after that vomit. Yeah. So because of this thinking, I choose the number E, the most likely we do after to make sure the diagnosis is the upper endoscopy to make sure that we have any problem in the GI tract or not. Yeah, I think that.
I agree with anh Hoàng. Since the question is asking for what confirm the diagnosis, so I think E will help with confirmations. Esophageal manometry used to, I think, evaluate refluxes or anything going on with the esophagus. Patients seem to have more of the gastric problem because the physical examinations reveal the epigastrium issue, so that's what I think. Abdominal ultrasound may be helpful at first to check for, but probably not helpful in confirming the diagnosis. Fecal elastate measurement is used to helpful in telling if the pancreas is working or not, usually to measure a pancreas insufficiency. CT angiography is for pulmonary embolism and stuff like that. Probably not helpful with the epigastrium issue. Plus, the patient doesn't have any shortness of breath, any chest pain, so I don't think that's necessary. So I think E, but I want to add that usually upper endoscopy with biopsy will reveal the diagnosis, I think. Not just upper endoscopy alone. That's my opinion.
Oh. That's it?
Yes, that's it.
Yes, sir.
Yeah, I think there's I think they call it red flag. Red flag mean depending on the patient, like his age and what the sign and symptom which we see of generalize a sign and symptom of, like we think he had cancer, like lose weight, sign of iron deficiency anemia, and his age above 50, with nausea or vomiting. That's all we call it red flag. Mean we should go direct to the endoscopy. Okay, so the right answer is endoscopy. Okay, as you say, you are right. Endoscopy, we can do the biopsy after that. That's for sure. When we do endoscopy, we will do when that's the first step we can do is endoscopy, and then we at that time we can differentiate between benign and malignant at that time, and we go after that. So the right answer is upper endoscopy.
So how about the other choice?
The other choice is not helpful because the first choice is esophageal manometry. We use it for.
So hold on, sorry. You guys, I think not many Vietnamese students or maybe doctor know about the esophageal manometry. So can you help us to know about this?
Yeah, esophageal manometry, we use it to, there's a three kind of dysphagia.
Motility.
Dysphagia. Yeah. Because the patient, he had dysphagia, so the people, they think he had problem with esophagus. So there is achalasia, which is a neurological destruction cell of esophageal muscles near the lower segment of the esophagus, near the stomach.
Or maybe he feels the esophageal spasm, right?
The other one, yeah, esophageal spasm. And the other one is, that's all causes of dysphagia. So we use esophageal manometry to differentiate all those three. If it's mechanical or it's like neurological causes. That's what we use for esophageal manometry. Okay.
Yes.
Esophageal pH monitoring, that's for
Maybe GERD, right?
yeah, for ulcer,
Also,
ulcer.
GERD,
The
like,
ultrasound is not helpful at all for those conditions.
okay. As I know, the esophageal pH monitoring used for diagnosis of GERD, gastroesophageal yes, plus GERD,
Big
GE,
one.
right?
Yeah, thanks for your
Oh, yeah, GERD, yeah. GERD.
maybe helpful for esophagitis, I think.
Yeah. How about the ultrasound?
I think ultrasound more like gallstones, maybe liver disease, stuff like that.
Yeah, gallbladder, some problem diagnostic for gallbladder pathology, like cholecystitis or cholelithiasis, as I remember.
I think with abdominal ultrasound, we cannot. Very difficult to diagnose the disease of the gastric because with abdominal ultrasound in the gastric, they have the air, and
yes.
ultrasound cannot see the air in. This is the problem with ultrasound. So
Yes.
for the liver, also with the gallbladder or the pancreatis ultrasound is okay, but maybe with the stomach, the ultrasound maybe difficult. I think that's.
Yeah, this poor visualized because
Yeah.
like how can we say as of this gas or like Dr. Han said, like air, so we cannot see anything inside. So the ultrasound is good for solid organs. Solid, yep.
Yeah, there is a lot of false negative for abdominal ultrasound. That's the reason, yeah. So we cannot depend on abdominal ultrasound. False negative.
How about another choice? Fecal elastase measurement, right? How you think about it?
It's for pancreatic insufficiency. It's measure the activity of the pancreatic enzymes.
Yeah, it's like a chronic pancreatitis. Usually, inpatient have the chronic pancreatitis. The patient can have the steroidea. Okay, so that's really so we can any question for this case? Any question? So can you guys hear Dr. Hassan talk? Because I believe when he talk, you have to. I can look at your face, and it looks like this. And I know, like have some a little bit about understanding. So just let me know. Just let me know if you guys cannot clear in any any point. Just ask them again to explain or ask him.
Yeah, just stop Dr. Most.
Yes, ask him. Ask him. He can explain it for that thing. Don't worry.
We're saying, don't worry.
Yes. So can we move the next question?
Anybody have any question? Hello?
No, sir.
Yeah. So when we do an endoscopy, as I say, we will go with the biopsy to see if it's positive or negative. So if it's the negative, after that we will search about another cause. If it is positive, so at that time we will do CT scan to confirm the diagnosis.
Like
okay.
we do endoscopy.
Confirm that's confirm it's adenocarcinoma and the staging after that. That's why we do the CT scan. We will do it after the endoscopy, not before. So sometimes these questions come in. They say you do CT scan first or endoscopy first. So we do endoscopy and CT for the staging. Okay.
Yeah.
I have one question about the ultrasound, abdominal ultrasound. In the Vietnam hospital, the abdominal ultrasound is very common. Yeah, they use the ultrasound for many for diagnosis many diseases. But I think in your opinion or your hospital, I don't know the abdominal ultrasound is useful or not. Can you hear me?
I hear you. Dr. Thong, can you just what he say explain to me?
He asked like in here we do a lot of ultrasound. I mean like for checking that's a very common test. But in US, how about the value of ultrasound? Maybe it's abdominal ultrasound.
Yeah, because with the CT scan we have more exactly. So yeah. So how about the abdominal ultrasound in your hospital?
I don't think so. We use ultrasound for anything for that.
Maybe for example, with this patient, he had diagnosis with the gastric cancer, and after that you say that we do the CT scan to staging. Yeah, and how about the abdominal ultrasound? Do we need to do the abdominal ultrasound in this case? No,
there is no indication for ultrasound at all because we cannot do the staging because we don't know the size, the lymph node. This is not diagnosed with ultrasound, with CT scan.